Welcome to Medical Grand Rounds. I assume I don't have to introduce myself to anyone in the room, so I will get on with it. Today's topic is a bit out of my comfort zone. We're going to talk about graduate medical education here at Roger Williams and the impact of the next accreditation system. I have no financial conflicts. This is advertised as a faculty development lecture. It is also education toward competency in systems-based learning. I will try to make this entertaining and fun, but I gotta warn you, I'm limited by the content. There's only a certain amount I could do. I would like to acknowledge all my predecessors who've helped me along the way. And Cindy Booten, who's in the back of the room, who's program administrator. And Cindy knows more about the ACGME than anybody in this organization, I can assure you, including me. I have some slides from Partners in Medical Education, which is a consultant firm that we use sometimes. And my daughter, as usual, has helped me with some technical aspects, like getting PDF files into PowerPoint. So I thought I'd start with a bit of the history of the internal medicine training program at Roger Williams. Some of the young folks may not know some of these people who preceded you, and I'd like to share their accomplishments and contributions to the program with you. So this is Dr. Paul Calabrese, who was the founder of the program, and one of the most sort of charming and persuasive individuals I ever met. And he was very instrumental in my career along the way, and I owe him a debt of gratitude for that. He came in 1968 from Yale and established internal medicine and some specialty programs. He was chairman and program director for internal medicine from 1968 through 1991, was director of the oncology program, and is largely responsible for the organization structure of the program as you see it today. Along with him about that time came Dr. McDonald to head the dermatology program, Dr. Kaplan, who was my mentor in rheumatology, Dr. Tucci in endocrinology, and Dr. Cummings came as a fellow in oncology. Other early faculty who were important were Dr. Zinner in infectious disease, Dr. Passero, who many of you probably did know when he was here, and Dr. Jacobs and Dr. Ryder, who ran medical residency for it when I was a resident and are still practicing in the community. Dr. Alan Whiteberg was an intern resident at Roger Williams and my chief resident. He trained in oncology at the Mass General and served as program director for internal medicine from 1991 through 2010. Associate program directors during that time were Dr. Passero and also Philip O'Dowd and Dr. Michael Macco, after whom the Macco Library is named. As to Roger Williams and its relationship with the ACGME, the first accreditation was in 1982. At some point during the early years, Dr. Calabrese was actually a member of the Residency Review Committee of the ACGME. And we've had continuous accreditation with 4 or 5 year cycles over the entire period of the residency. The last site visit was in 2011, and we were told at that time that the next anticipated site visit would be 2016. I knew at the time that that was sort of too good to be true. And it turns out it was. I'm going to explain to you what the new plan is. So before we get into the meat of it, I thought I'd run through some of the acronyms. Now, the ACGME is really good at acronyms. They've got a whole alphabet soup, all of them. To begin with, many program directors probably can't actually tell you that ACGME stands for Accreditation Council for Graduate Medical Education. Of course, GME stands for Graduate Medical Education. NAS stands for Next Accreditation System. EPAs are Entrustable Professional Activities. The asterisk means that I couldn't actually find entrustable in the dictionary. I think not only do they make up acronyms, but they make up words. Entrust is a word, but entrustable, the spell checker tosses that one out. Clear, clinical learning environmental review. We're going to talk about that in some detail. I don't know exactly what ADS stands for. I'm sure Cindy does, but it's the mechanism in the ACGME where you enter data about your program. You know what it stands for, Cindy?
Accreditation Data System.
Accreditation Data System. CCC is the Clinical Competence Committee, which at the Roger Williams is chaired by Dr. Tucci. The members are myself, Dr. Shaw, Dr. McCormick, the Associate Program Directors, Dr. Etienne, Dr. Braun, and various other important faculty who meet to review the progress of the residents. Now, the way the old ACGME worked was the PIF and the site visit. And the PIF was the Program Information Form. And the site visit was when the ACGME sent a professional reviewer to your hospital, and that person would meet with the program director, review the policies and procedures and schedules, and ask questions like, how does your program ensure that the residents don't suffer from fatigue? And I would show them the form. I have this form. I make sure they do the duty hours. How does the program ensure that they get 130 half days of clinic time? Well, we have the schedule. We show them the schedule. And, on and on like that. We show them all our documents and paperwork. And then they would, the site visitor would meet with some of the faculty members and ask them the same questions and make sure the faculty said the same thing that the program director did. And then they would have lunch with the residents, which some of you probably remember. Jason's nodding his head back there. And make sure that, everybody's happy and getting fed and getting learning and stuff. As far as I know, they never looked at the hospital. They did not talk to nurses or patients or anything like that. And it was largely about the process of how we do our thing. They would report to the Residency Review Committee. They would grant accreditation, if they thought you were doing a good job, they'd give you 5 years. If they thought you needed a lot of improvement, they'd give you 1 year or somewhere in between. And they would say, see you back in 2016, try to behave. And we would all say, oh, thank God that's over, and we go back to our business and forget about it for 4 or 5 years. It was pretty unpleasant stuff, and it really was a big test of the program director's ability to get all these forms and documents through, and that's what it was kind of about more than anything else. So, the system is going to change, and the first announcement about that was Dr. Naska's paper in the New England Journal, March of 2012, entitled The Next GME Accreditation System, Rationale and Benefits. And he stated in his paper that the aims of the next accreditation system would be to enhance the ability of the peer review system to prepare physicians for practice in the 21st century, to accelerate the ACGME's movement toward accreditation on the basis of educational outcomes, and to reduce the burden associated with the current structure and the process-based approach. Reducing the burden sounds good, and frankly, so does changing to a more process-based approach rather than, or an outcome-based approach rather than a process-based approach. So the next accreditation system, there will be 2 types of surveys. One is the Institutional Accreditation Survey, which will focus on the requirements. And I'm not going to say too much more about this. This is going to be important for Dr. Libby, who's our DIO, to understand. I assume that this will be more like the old site visit where they come review all our documents and make sure that the GMAC committee is overseeing the specialties and educational programs in the hospital. So I'm not going to talk too much more about that at this point, but we will talk about the CLEAR visit because that's the one that's going to affect the people in the room most. So CLEAR, I said, is Clinical Learning Environmental Review, and it's a review that focuses on the clinical setting. So the ACGME has recognized that supervision and teaching patient safety and quality improvement are as important as duty hours. Now there's a revelation. So the CLEAR visit will focus on the educational environment and will have an aim to promote safe, quality patient care. The survey will be conducted where the residents receive their clinical training. The underlying principle is that safe healthcare settings are necessary to prepare residents to be safe healthcare practitioners. CLEAR's 6 areas of focus will be patient safety, quality improvement, transitions of care, supervision, duty hours with a focus on fatigue mitigation, and professionalism. Nothing here about can you take care of congestive heart failure, but you see what their emphasis is. So, examples. Do residents report patient safety issues? Do they report errors, unsafe conditions, near misses, those things? Do they participate on interprofessional teams that promote patient safety? In the area of quality improvement, are the GME leadership and faculty integrated into the quality improvement activities? Do residents learn how to identify opportunities for reducing health disparities? Do residents use data to improve systems of care? There's going to be a big emphasis on transition, the handoffs, the sign-outs. Is there effective standardization and oversight of transitions of care? Does the institution facilitate professional development for residents and faculty about transitions? Do we have policies? Do we monitor residents? Do we have mechanisms to report inadequate supervision? And would the residents use it, or would they be intimidated? As far as duty hours and fatigue mitigation, they have said they want the faculty and the residents to be educated about fatigue. We do that. We still have to oversight and monitor the duty hours. And then we have to assess professionalism. Do we monitor the behavior of residents and faculty? Are we truthful in our scholarly pursuits? Do we report accurately to ACGME? Those types of things. So when is this going to happen? Well, it started happening in September 2012, and the cycle is through February 2014. And they are going to try to do the 400 major sites, those with more than one accredited program, which would include us, during that time. But it will be beta testing, and the data will be used for a formative evaluation, but not in making accreditation decisions, which it should be because we're supposed to be accredited through 2016. But they're going to come and do every program during that time frame, so they could call us tomorrow and say that they're coming in 2 weeks. So we need to try to be prepared for that eventuality. And then as of July 1st, 2014, the clear visits count toward your accreditation. So they contact the DIO, they give you 10 days to 3 weeks notice. They will come with, for us, I suppose 2 or 3 visitors, some of whom will be professionals, and a new aspect of this is that they will include 1 peer visitor. So somebody from an institution that has a program like ours who volunteered to come and do the survey here. They will interview the CEO. That's on my to-do list to tell Ken Belcher about that. I think he knows. They will involve the hospital leadership, Chief of Patient Safety and Quality, Nancy Fogarty, who's here today, would be involved for sure. The DIO, the GME office staff, Barbara and Sue. The GMEC chair, who is the same as our DEO here. And the representatives to the GMEC from the residency. Where's John Skolecki? Yeah, he's one of the ones who's been there regularly. We better tell John about this. He's going to have to step up. They will talk to program directors, and then they want peer-selected residents from all the core programs and the larger fellowships. So they will spend probably 2 days, I would guess, for a program of our size. They will discuss the 6 areas of performance with the hospital leadership, and then they will take a walk around the hospital, guided by the peer-selected residents and fellows. They will talk to nurses. They'll talk with other residents and physicians on the units. They might talk to patients. They could ask people in the hall. Who knows? They might come back in the evening, and then they will provide an exit conference with all of the participants. So they might ask you when they're walking around, how do you report an event or a potential safety concern? Do you actually do it, or do you have the nurses do it? Do you get feedback about what happened when you reported a concern? Do you know the hospital's quality goals? Do you know how individual programs relate to the overall plan? Does the faculty know any of this stuff? Then they'll have a meeting, and I've been told that they might get everybody in a big room like this one, ask more questions. I've been told they have been experimenting with an audience response system where you answer yes or no and it all shows up on the screen. And the logistics of all this are going to be difficult. You know, the hospital's going to have to be able to get all this together and make it happen. I mean, you've got to account for people on call and and work to be done and all this stuff. So logistics will be difficult. After the visit, they'll send a written report and they'll send their evaluation to the ACGME committee, and then a while later you get a final report and it becomes part of your institutional portfolio. So, to review, 2 types of surveys. The clear visit is the one that focuses on where the residents train, the clinical learning environment. We're in the middle of the 18-month cycle for the beta visits. There's 6 areas of focus. Short notice, teams of visitors, a couple of days. You're going to meet with hospital leadership as well as residents, and it involves walking tour of the clinical units. The 6 areas of focus: patient safety, quality improvement, transitions of care, supervision, duty hours, and professionalism. Beta testing in the first 18 months, starting July 2014, it forms the basis of the accreditation for the program. That's the first half of my presentation. Does anybody have questions about the clear visit and the new ACGME from that perspective? It must be crystal clear. Okay, part 2, the evaluation system. How we evaluate residents and fellows' progress. So the ACGME will require programs to begin measuring outcomes and shift away from process. The tools and the criteria will change, the reporting system will change, the clinical competence committee will do more work. The core competencies do not go away. You all know the 6 by heart. It's patient care, medical knowledge, interpersonal communication skills, practice-based learning, professionalism, and system-based learning. The problem is evaluation of the competencies. So the old system kind of explained the extremes, but left the middle up to the evaluator. It kind of assumed that you knew a lot about the resident, which you might actually not know. It usually resulted in 6s and 7s. I was often in the middle of a competence committee meeting thinking of Garrison Keillor's Welcome to Lake Wobegon, where all women are strong, the men are good looking, and all the children are above average. I think it is the case that the new system will eliminate some of that grade inflation because it has fewer numbers and is more of a visual analog scale. And it marks your progress toward your goal rather than giving a number score from where you were today. This is the old form, which you know and love. And you remember this, you have to circle a number someplace in there and your 2 extremes are explained. It is difficult, and it's a good thing that they're trying to improve the system. So let me just digress for a minute to talk about the 2 competencies that are the most difficult, because they're not going away. The most difficult ones are practice-based learning and improvement and system-based learning. And they're difficult to understand and difficult to evaluate. So the first part is the understanding. Practice-based learning is using feedback and self-reflection to improve your knowledge and practice. So if Dr. McCormick tells you that you need to write a more detailed discharge summary, you have 2 choices. You can either say, I'm not doing that, what does she know? Or you can set about to write a better discharge summary. If you write a better discharge summary, you are practicing practice-based learning and improvement. System-based learning is using the healthcare system to provide care that is cost-effective, of high quality, and evidence-based. So here they are, some examples. Practice-based learning is self-evaluation, lifelong learning, teaching patients, teaching your peers, and scholarship. I've always been a little bit annoyed with this. Scholarship kind of gets a little niche at the bottom of practice-based learning improvement, but there it is. That's the way it is. Systems-based learning. Can you work with a multidisciplinary team? Are you able to coordinate care? Do you do good discharge planning, good handoffs? So there's a little overlap here. Can you advocate for quality care? Are you on hospital committees, residence council? So, when Mike and Nadine and some of the residents came to work with administration on improving the technical issues in the residence clinic. That is an example of system-based learning and practice, which is very important and things that you should get credit for doing. And the ACGME wants to hear about that. So, how are we going to do the new system of evaluation of the competencies? The 6 competencies still remain, but now they have written 21 sub-competencies to help us. In addition, they have devised 142 milestones and a bunch of, well, entrustable professional activities I think we're supposed to figure out. I'm not terribly sure about that. And when I say they, I mean this has been a pretty long process involving lots of educators and physicians and administrators who, had a lot of meetings and given a lot of thought to this. It's not just something that Dr. Nasco dreamed up one evening. So let me start with trying to explain entrustable professional activity. It is something the public entrusts a physician to be able to do in the simplest form. Tasks or responsibilities to be entrusted to the trainee once he's demonstrated specific competence. It should be independently observable and measurable. It's a means to translate competency into clinical practice, and it's recommended a program have 20 or 30 EPAs. A final EPA would be the activity that the public expects, for example, managing diabetes. They expect an internist to manage diabetes. A training EPA would be a component of that that leads you to be able to manage diabetes, for example, teaching a patient how to use insulin. So, let's move now to the sub-competencies, for which there are 5 in patient care, 2 in medical knowledge, you can see the list there, for a total of 22. And I have written them all out. I'm not going to go through them all in complete detail, but you can look at them as we go through. So these are the sub-competencies for patient care. Can you get a history? Can you develop a comprehensive management plan? Do you show the ability to manage patients with progressive responsibility as you go through your training? That's, you're getting better. Evaluate procedures. Request and provide consultations. For medical knowledge, they divide it into clinical knowledge and knowledge of tests and procedures. For problem-based learning, can you monitor practice with the goal toward improvement? Do you learn and improve via feedback? Do you know how to use performance audits? Stuff like that. Interpersonal communication. Can you communicate effectively with patients and caregivers, with interprofessional teams? Can you complete your medical record on time? By the way, I get reports from the record department. I don't know if you all know this, but they tell me who's deficient in dictations. It's been very good lately. The medical residency has not been deficient in dictations. Good work. Professionalism. Do you have respectful interactions with patients, caregivers, and the team? Do you accept responsibility? Do you follow through? Do you show up on time? Do you do the work without complaining? Systems-based practice. Do you work with the team? Again, a little overlap. Recognize errors. Aware of the forces that impact the cost of healthcare, and again, the transitions. So those are the sub-competencies. Now I'm going to talk about millstones. That's a millstone. It's a big stone made out of rock. And this is how you use a millstone. You hook it up to a donkey and you drag it around, and it crushes corn or whatever. And I think the idea is that if you do this for a few years, you get tired of it, and you feel like that millstone is weighing you down. And if you get really tired of it, you tie it to your neck and let yourself off the cliff. But we're going to talk about milestones. We're hoping that the milestones don't turn into millstones. A milestone is a marker that tells you how far you've been and how far you have to go, like milestones in pediatrics. These are the milestones. These are the milestones for patient care. Can you take a history? Can you review records? And then in the column on the right, you see how long the ACGME figures it should take you to be able to achieve that milestone. So by 6 months, you should be able to do a basic history. By 9 months, you can review family records. By 18 months, and down the line. And the same with physical examination. And these milestones are published and available. They were constructed as a joint project between the American Board of Internal Medicine and the ACGME. They're on both websites, and they look like this. And this is what you see when you open that up. You have the sub-competency at the top. So we went through the 22 of these. And this is patient care sub-competency number 1. And then down below they list the milestones that are to be used to evaluate your progress in that sub-competency. So here's the history stuff. Can you get a history? Are you very accurate history? And then there's an aspirational column, which is what you hope to be even after you finish your training. And again, we don't have to look at every detail, but there are, what did I say, 142 of those. And they are patient care 2. This is about management planning. Can you do that? Patient care 3, you require direct supervision, indirect supervision, are you independent? Can you manage complex patients, intensive care, performing procedures, basic technical skill, advanced technical skill, maximize patient comfort. Consultation care is patient care 5, the same kinds of things. And then when you get to the end, there is a box at the bottom that says that, the Competence Committee says, yes, you are developing satisfactorily on the curve toward becoming what they call the learning trajectory to achieve the competency for unsupervised practice by the end of your training, yes, no, or marginal. Similarly, for clinical knowledge, for medical knowledge, there's MK1 and MK2, and you get check off at the end if you're making satisfactory progress. So that's what they look like. And then there's this idea that the EPAs and the milestones have to mesh and work together. All I can do is give you some examples. I really don't fully understand this myself, even though I've tried pretty hard. But an example that's given is learning how to drive a car. So you have curricular milestones, which would be using the gas pedal, know the rules of the road, adjust the mirrors. And in training EPA would be drive the car with your parent in the passenger seat and prove that you can do that. And end of training would be the parent tells you to drive the car to the store and see how you did. This example doesn't really resonate that well with me. Actually, the way I taught my 3 children how to drive was I took them down to Cold State Park in the spring when no one else was there. I put them in the car and said, now drive. And they said, but Dad, I don't know how to drive. And I said, well, give it a try. The car will teach you. This is true. And it really worked very well. They have very little anxiety about driving. And they all are good drivers and have great records. And it's actually kind of the way I teach rheumatology when I think about it. There's a patient with rheumatoid arthritis in the room, and I want you to go learn something. But I don't know how I got off on that track, but this is the example of an EPA. I guess I still made it drive to the store and back and prove that they could do it. So, managing diabetes, the curricular milestone would be do the history, look for complications, do the exam, work in collaboration with the dietitian. The EPA would be diagnosing and treating the patient on your own. The end of training would be no supervision. And then the NAS says not only you evaluate it, but you have to stratify them as being novice, proficient, or advanced in the management of diabetes. Something like that. All right. So here's where the evaluation part comes the nuts and bolts. The committee is to select a point somewhere along this continuum that represents your progress in that sub-competency as determined by the milestones. And you can see it doesn't have numbers, it's more like a visual analog scale. And it also says that you were allowed to select a response box and a line in between, showing that you have demonstrated competency in all of these and a few of these. This is kind of like circling 6 and 7, you know, like we sometimes do. But you get a score along those lines representing your progress in each of the 22 subcompetencies. Now, here's the rub. We are going to be required to report this stuff to the ACGME every 6 months on every one of you. I'm not sure what they're going to do with that information. I mean, I think they are really interested in the aggregate of how people are getting scored and stuff like that. They're not going to come back and say, you know, Triana, you're not doing so well. And there is something that you're probably not aware of, which is the ABIM fast track system, in which your scores, your evaluation numbers do get reported to ABIM by the programs. So this reporting will eliminate that and combine those two systems, I believe. They're trying to make that happen. And how exactly this is going to be done is not entirely worked out, but it sounds like it'll be a web-based system into which the Clinical Competence Committee has to enter the data. Any questions about that part? Alex?
So you need to get information from other people, right? Feed information.
Yes.
Every physician who sees the resident will have to evaluate the resident, give information to the clinical competence committee for us to make a decision.
Yes, and those evaluations need to be more specific to the activities that are going on. And I know that this is already happening at Rhode Island Hospital. They are going around to each elective rotation and saying, you have to give us more milestone-like, EPA-like definitions or criteria for what you expect the residents to get out of your elective or out of your rotation or whatever. We're not all going to be able to just use the generic form anymore. So you're right. All those experiences have to come into the Clinical Competence Committee, and then the committee has to make a summary assessment on those 22 subcompetencies.
I'm on a content-based milestone, for example, professionalism. As a resident goes through their training and makes it through all these milestones and then graduate competent, and then go on to become a fellow, do they use the same competencies in professionalism? Do we start them back at totally unprofessional and work them again through professional?
That's a good question. I haven't heard it put in that way, but at least for medical knowledge, you would see it as a continuum on which they build. But
yeah, that would make sense.
yeah, but professionalism isn't so much a process kind of thing. It is sort of, well, people do make progress, but
You can use me as an example.
yeah. Excellence in professionalism. Yeah, I'm sure a lot of that is to be worked out, and the whole how the subspecialties fit into this has a lot of open-ended stuff. I know a little bit about it, which I think you'll talk about. But just for a minute about mind evaluation, Cindy and others have been working on getting us an electronic evaluation system, because doing all this on paper, as you can see, you know, the number of questions to be answered has multiplied quite a bit. And the paper forms are just not going to be feasible. So we are working through the process of, I think we have signed a contract with My Evaluation, which is a very good electronic evaluation system which can be used for not only the subcompetencies and the milestones, but for residents evaluating faculty, evaluating rotations, evaluating peers, the whole shooting match. You can use it for monitoring duty hours, you can do tracking and statistics and all those sorts of things. So, we could have a clear visit at any time. July 2013, the NIS officially begins. In fall of 2013, the department will file an annual report through ADS. December 2013, the Clinical Commons Committees will start reporting on each resident via a web-based reporting system. And in the winter of 2014, they will do another round of resident faculty surveys to see how it's going. As far as subspecialties, the target is July of 2014 to enter NAS for subspecialties. And the subspecialties will need to have EPAs and milestones, and each subspecialty will have to have its own clinical competence committee. So there are 3 ways to figure this out, Dr. Rahar. One is to just make your own for HEMOG. 2 would be that we combine all the subspecialties and have one committee from them. 3 would be that we use the existing clinical commons committee and you all come. But somehow the subspecialties are going to have to figure out a way to do this final collaborative evaluation and do it every 6 months. So just to wrap up with some thoughts about how we can prepare for these changes, we need to start thinking about competency-based milestones and EPAs. We need to have meetings and have the residents select people who are willing and able to serve as tour guides and represent the program for their clear visits. We need to be very sure that the residents are participating and active on the committees, and Nancy Fogarty has said about doing that, and we're going to track attendance at committees to make sure this is actually happening. And while you're there, try to get something out of it. We're going to have to start thinking about educating more and evaluating more about handoffs, transitions, discharge summary, and those areas of emphasis by the ACGME. And then there's this, I can't think of a better way to describe it, but thinking backwards, which is, it's kind of like preparing for a test. You know, you have to think about the questions, and then what happens is they ask you a question in a way that you don't understand the question very well, and it makes you think you don't know the answers. But you do know the answers. If you stop and think about it, you do know the answers. And so an example I've thought of is that before this meeting today, if somebody stopped you in the hall and said, does your program educate you about systems-based learning? You would say, I don't know, what's that? But after this meeting today, if somebody stops you in the hallway and asks you, does your program educate you about systems-based learning, you would say, well, yes, Dr. Zimmerman talked to us about the ACGME last week. And that's a system that's important for medicine, so that must be systems-based learning. You see what I mean about thinking backwards? You gotta understand the jargon, and think about the questions, and then run through your database of experiences and see what